Good afternoon, friends. Thank you, Suven, for having me here. Suven's course on this particular topic, his device, has been going places. I'm really proud of what Suven has been doing. I have nothing financial in my presentation. Over the years, my dependence on pupillary devices have come down. That's what I have noticed. And from time to time, I do still use devices. In this era where Malugin's ring is so common, Suven's Bhattacharya's ring is becoming popular, iris hooks still play an important role for various reasons in Western as well as in the Eastern Hemisphere. So in this presentation, I'm going to show you the basic technique which I employ for the iris hooks, which have been giving me very good results. This is an intumescent cataract. Pupil is not really very small. However, in such cases, you want complete control over the rhexis. That is the rate limiting critical step. So I wanted to use iris hooks. Before you make the paracentesis tracts, make sure that the eye is very well inflated. The four paracenteses that you are making right now, make sure that they are symmetrical. Either you get a square shaped pupillary expansion or it is rectangular. Some people believe that you should be using five hooks, and some people believe that you should be using a rhomboid pattern of application of these iris hooks. Do not make the incision very peripherally through the conjunctiva, because insertion of the device may be quite difficult. The conjunctiva comes and gets entangled with the iris hook, and then maybe conjunctival chemosis as the surgery goes by. And make the paracentesis tracts near vertical, because if you make it absolutely vertical and you are dealing with an intumescent cataract, very shallow anterior chamber, there is always a possibility, provided if you are using a blade that is not too sharp, or if a globe is not very firm, you can, in the inertia of the blade can take it through the iris, and you can end up damaging the peripheral iris and the anterior capsule. Now, this is the second stage. The second stage go on in 3 steps. First, I would be placing the 4 devices inside the eye. I will not bother to engage the pupillary margin with the iris hooks at this stage. Why I do it will be clear in some of the videos that I show subsequently. So, it is important to make sure that the devices that you place inside the eye do not damage the anterior capsule. The next step is engaging the pupillary margin with the iris hooks. So that is done extremely carefully. My next video clipping will show further details on that. At this stage, if you see carefully, I have not bothered to retract the pupillary margin to the periphery. If you pull the iris pupillary margin to the periphery, engagement of the subsequent iris hooks become quite difficult. So in stage number 2, I just engage the pupillary margin with iris hooks, and once that is done, then the pupillary margin is expanded to whatever size that you feel comfortable with. It is not really necessary for you to all the time, to pull the pupil to the extreme periphery, because it results in sphincter tears, and postoperatively there may be issues with, cosmesis. In certain situations, if your paracentesis tracts have not been kept properly, if they're too oblique, the peripheral iris is very close to the cornea. So peripheral anterior chamber is much shallower than the central anterior chamber. And if you do not take further precautions, as you go inside the eye with the phaco tip or with the sharp chopper or even the Sinskey hook, you may end up engaging the iris tissue, and that may result in iris chafing. If you're lucky, or if you're unlucky, it can even result in iridodialysis. The same principle holds true when you're using, now just before the IOL implantation, I would be relaxing the iris hooks a little bit, as you see here. Let the peripheral iris fall back. You have a deep anterior chamber in the periphery by this maneuver, and since the rhexis margin is already visible and you are working in the pupillary center, so it is not really difficult for you to put the lens in the bag, and using this maneuver, you would have definitely saved the pupillary margin, saved the iris tissue. I'll just go to a video clipping which. Now, this particular gentleman was an 86-year-old one-eyed patient. He had high astigmatism, so I wanted to use a toric intraocular lens for his astigmatism. So I had to play extremely safe. So I decided to use iris hooks. In a routine case, I would not be using an iris hook, but it's a very, very hard cataract. And in hard cataracts, many a time, we start the chopping from the periphery. Once we get the full thickness chopping, and then you bring it to the center. So I wanted to use the iris hook here, and let's see what happens. So the next difficulty that you encounter here is, all hard cataracts have to be stained with trypan blue dye. The capsule has to be stained because you want to see the rhexis margin. You do not want to damage the rhexis margin with your chopper. Neither do you want to use the phaco, with the phaco tip you phaco the rhexis margin. So these are the things that one has to be very careful. Now, if I try to stain that anterior capsule with trypan blue dye by not modifying my techniques, I will end up staining only the central area. And subsequently, when I remove the central anterior capsule by performing the rhexis, I really don't have any view of the anterior capsule. So I use a special technique for staining the anterior capsule in these kind of situations. Gaurav had shown you one technique here, but what I'm going to show is very practical. This is Helon 5. Helon 5 is placed in front of the incision, just outside the incision. This acts as a very effective plug. And subsequently, I take my trypan blue cannula across the anterior chamber. You have not lost the anterior chamber, though there is no air bubble right now, and inject the trypan blue dye just under the iris. So there is a capillary mechanism. So the trypan blue dye diffuses to the extreme periphery. The entire anterior capsule gets very well stained, as you will see here. And subsequently, of course, an air bubble is kept to make sure that the trypan blue stain is quite on the deeper side on the anterior capsule. I always use a soft shell technique. So viscoat was injected into the center of the anterior chamber, and subsequently I used Helon just in front of the anterior capsule. Now it's a question of getting the pupil to dilate. Now the problem here is the pupil is already mid-dilated, and it is always difficult to engage the pupillary margin with the iris hook in this kind of scenario, because iris plane is flat. And if you want to engage the iris plane with the iris hook, you have to make sure that the plane of the hook is perpendicular, is at right angles to the iris plane. And when you are working in the periphery, where the iris hook is quite oblique or almost near vertical, it's very difficult to get the angle straight. So you follow the technique that I had shown. You can use Helon 5 or you can use even Helon G. Inject a little bit of it under the pupillary margin. Don't inject too much, because if you inject too much, then the anterior chamber becomes shallow, and subsequently you find it difficult to negotiate the iris hook across the anterior chamber. It gets ensnagged with the iris tissue, and then there's all mess. Once the first hook has been engaged, I was having certain difficulty with the second hook, because of the angulation. You have to make the iris hook quite vertical, and it's quite difficult. And in the process, you did see the lens move. It was quite a hard cataract, weak zonules. So I abandoned that second site and then came temporarily again. And it was easy for me to engage the pupillary margin. So then I went back to the second side, towards the nasal side. This was the patient's left eye, and injected a little bit of OVD under the pupillary margin. Here, of course, it is difficult to inject the OVD because of the angle of attack. It is difficult to get under the pupillary margin. So here, I will be engaging the pupillary margin, not exactly opposite to the paracentesis area, but I'll come a little bit to the side. You see? A little to the side, because iris has already been elevated from the anterior capsule. So there is some space, some friendly space for you. And then the pupil is stretched. Here, of course, I wanted to stretch the pupil well. I made a large rhexis about around 6 millimeters in size. And you see, using this maneuver, I have been able to get a very uniform staining, deep staining of the anterior capsule, which is definitely going to make my subsequent phaco very safe. Because since I can visualize the capsule, the chances of me damaging the rhexis margin with the Swinsky hook or with the chopper or the phaco tip is almost nil. So thank you, Suven. I think my time is up. Thank you very much for
Thank you, Arup. Despite losing 2 minutes, I think you really finished on time. Thank you so much.